So, despite its proven efficacy, there really remains this inequality in access to mechanical thrombectomy in the United States, with significant disparities we know that are influenced by things like race, geography, socioeconomic status, and even systemic healthcare factors. This presentation is really aiming to outline some of the disparities and highlight those pivotal roles EMS and education can have in bridging the gap. And one second, my screen is stuck, I think. There we go. So, race and gender disparities do exist in the incidence, prevalence, morbidity, and mortality related to stroke in the United States. And in regards to race, the incidence of stroke is higher in Blacks compared to whites in all categories of stroke. Studies indicate that Black and Hispanic patients are less likely to receive mechanical thrombectomy when compared to white patients. And in one review of AHA Quality Improvement Registry, looking at the time period from 2014 to 2021, DeRue et al. Found that white patients were about 2.3 times more likely to receive mechanical thrombectomy compared to non-white patients. Now, ethnic and racial disparity in receiving mechanical thrombectomy can be due to many underlying factors, such as hospital accessibility, as well as time of hospital arrival, which we know can be impacted by several factors in and of itself, like underutilization of EMS. And in one study by Smith et al., they found that Mexican Americans were less likely to use EMS in comparison to non-Hispanic whites. If patients are delayed in hospital presentation due to less utilization of emergency services, then it makes sense that patients are less likely to meet the window for mechanical thrombectomy. Longer last known well to arrival times may also be due to a delay in recognition of stroke symptoms, lack of stroke awareness within a community, and decreased stroke literacy for an individual. Minority patients also tend to present with increased severity of stroke symptoms and have increased risk factors like diabetes and hypertension, and they are more likely to have lacunar strokes, which in essence makes them less eligible for thrombectomy, perhaps also explaining some of the disparity. Now, Drew et al. Found that patients with Medicare insurance were significantly more likely to receive mechanical thrombectomy compared to those without. It's thus highlighting this influence of insurance coverage on treatment access in the United States. Medicare insurance recipients were 33 and a half times more likely to receive mechanical thrombectomy compared to those without Medicare. And females were more likely to have Medicare than males. In another study, socioeconomic status played a significant role in the utilization of thrombectomy. The study showed that mechanical thrombectomy rates were higher among privately insured patients than among those with Medicare and uninsured patients. It has also been shown that women are more likely to recognize stroke symptoms, which could potentially explain why females are more likely to undergo thrombectomy, since they are recognizing symptoms earlier and they present to the hospital in a timely manner to meet the criteria for thrombectomy. Previous studies have also shown that there's disparity in knowledge of stroke along with MI symptoms that are influenced by race and socioeconomic factors. Low-income individuals and those with less education are also less likely to receive mechanical thrombectomy in the U.S. And these factors are often due to things like limited healthcare access, lack of awareness, and transportation challenges. Access to mechanical thrombectomy varies significantly across different regions in the U.S., with areas like East, North Central, and West South Central regions having lower proportion of patients treated with thrombectomy in the United States. Compared to the national average, the number of patients undergoing thrombectomy is also much higher in urban than rural areas, which is much what you would think. In one study, approximately 1/3 of the US population lives more than 60 minutes away from a thrombectomy capable center. And in another study, only less than half of the US residents had access to a thrombectomy center within 60 minutes by ground and about 2/3 by air ambulance. However, as you would suspect, rural areas are disproportionately affected. And in rural areas, only about a quarter of patients initially received care at a thrombectomy capable center, compared to almost 70% of patients within urban areas. Now, evidence shows that patients who initially received care at a thrombectomy center were substantially less likely to undergo thrombectomy compared to patients who initially received care at a thrombectomy hub. And I think I might have misspoke, and I meant those with receiving care at non-thrombectomy centers. And in one center, about a quarter of patients in the US were transferred to an endovascular center in order to receive thrombectomy. And of those patients, only about 44% of patients actually ended up receiving thrombectomy. So these facts are highlighting some of the disparities in where patients arrive between the non-thrombectomy and thrombectomy centers. Now, pre-hospital care is a key focus because deficiencies in early recognition, triage, and transport have clear downstream implications for treatment options and clinical outcomes. Limited pre-hospital care and emergency medical resources are common sources of inequality in many cities and regions. Sources of disparities may relate to differences in hospital capabilities, such as staffing and infrastructure and related resources. And some barriers to stroke care relate to state-based issues, potentially driven by state policy, rules, and regulations, and or financial concerns. Some of these issues are driven mainly by insurance issues and limitations. In the US, EMS are encouraged to utilize stroke screening and severity tools, which can aid in early identification of large vessel occlusive strokes in the pre-hospital setting, which then facilitate timely triage and appropriate triage to the right centers. Implementing protocols that allow EMS to bypass non-thrombectomy capable hospitals in favor of the thrombectomy capable centers can reduce treatment delays and reduce mechanical thrombectomy disparities. And of course, with these algorithms, we want to outline the differences in the triage bypass acceptable limits for suburban and rural areas. And in areas where I'm at in Texas, we are also working on our algorithms for pediatric patients that are suspected of having strokes. Now, triage algorithms risk becoming overly complex for such a high impact but low frequency event as acute ischemic stroke. Keep in mind that acute ischemic stroke accounts for less than 5% of EMS transports, ED visits, and hospital admissions. Ambulance-based telestroke is one way to help reduce this gap in knowledge and experience. It enables stroke specialists to evaluate and provide guidance before hospital arrival. EMS personnel can engage in real-life consultation with neurologists during transport, ensuring preparedness at the receiving facility and expediting care. Deployment of mobile stroke units equipped with CT scanners and telemedicine capability is another way of enabling on-site diagnosis and initiation of treatment, specifically reducing time to intervention and bridging some of the disparities in access to stroke care. Education is yet another key intervention aimed at reducing some of the disparities in mechanical thrombectomy and can have an impact at all levels of care. Education has to start with increasing public awareness, like Be Fast and FAST campaigns, which have been instrumental in educating the public about stroke symptoms and the urgency of seeking care. Tailoring education efforts to high-risk communities, including non-English speaking populations, can also improve symptom recognition and prompt EMS activation. Now, education is a key step for EMS as well. Regular training sessions for EMS personnel on stroke recognition, use of pre-hospital stroke scales, and updates on treatment protocols are essential. Likewise, conducting mock drills and simulations can enhance EMS readiness and response efficacy in real-world scenarios. Additional steps to take to reduce disparity in thrombectomy care in the U.S. include advocating for policies, much like what Dr. Fifi was mentioning. These support the expansion and improved access to thrombectomy-capable centers in underserved areas and provide funding for EMS training and resources. Also, establishing registries to monitor thrombectomy utilization and outcomes across different demographics can help identify the gaps and inform targeted interventions. And finally, fostering partnerships and collaborative networks between regions with an abundance of resources and those that are resource challenged, as well as hospitals, EMS agencies, and community organizations, all with the goal of streamlining stroke care pathways and ensuring cohesive response systems. So, in conclusion, addressing these disparities in thrombectomy access require a multifaceted approach that encompass systemic reforms, community engagement, and continuous education. EMS providers stand at the forefront of this endeavor, serving as the critical link between stroke onset and definitive care in the U.S. By empowering EMS through training and integrating advanced technologies, and by educating communities about stroke recognition and the importance of timely intervention, we can move towards equitable stroke care for all. Thank you.